Good evening, everyone. Welcome to ZimV Institute online webcast. My name is Clara Bertram. My colleague Dipali Nagotka is here with me today, and we are your hosts for this online webcast. We would like to inform you in advance that we will not entertain any questions during the Q&A, as this is a rebroadcast of a recorded session and not a live webcast. Thank you, and do enjoy the presentations.
Good evening, everyone, and welcome to Live on Tuesday, hosted by ZimV Institute. Thank you so much for joining us. My name is Anne-Marie Pitre, and I am the North American Medical Education Manager at ZimV Dental, and I will serve as the moderator for this program. The topic for today's program is Mastering Anterior Immediate Implant Aesthetics, a live surgical approach for precision, efficiency, and predictability. I'm excited to be joined by our presenter, Dr. Garrett Golden. Let me tell you a little bit about him. Dr. Golden earned his Bachelor of Science in Biology from Virginia Polytechnic Institute and State University. He earned his Doctorate of Dental Surgery from the Medical College of Virginia and subsequently completed his periodontal certification and master's degree at the University of Texas Health Science Center at San Antonio, graduating with the highest honors. In November 2000, Dr. Golden became a diplomat of the American Board of Periodontology. He has practiced periodontics, focusing on minimally invasive strategies with an emphasis on immediate aesthetic zone and full arch dental implant procedures for over 30 years. He has lectured locally, nationally, and internationally. At this time, it is my pleasure to welcome Dr. Golden. Welcome, and thank you so much for joining us for this program. Will you please tell our viewers a little bit about what you'll be presenting this evening?
Sure. That was a mouthful, Anne-Marie. Happy Tuesday, everybody. Happy Veterans Day, especially to the veterans or people that have veterans in their family. We're going to cover maxillary anterior immediate implant placement with digitally generated provisionals. And then we're going to cover some dual zone technique and with and without CT, because I think it's sort of
Oh, that sounds great. People always love videos and seeing how you do it live. And at this point, Dr. Golden, I'll invite you to share your screen, and we look forward to seeing this presentation.
Okay, thank you. Let me minimize that. Yeah, so welcome everybody. Like we just said, we're going to cover this anterior immediate topic. Thank you, ZimV. Appreciate you guys as always, and any invitation to speak. I want to just recognize super quickly a few people, and groups of people. One is the group of our staffs, right? Our teams. Like we can't live without these people, so it's important to recognize them as often as we can. And so I'm recognizing our group at Northern Virginia Periodontics, but also all of your all's teams. Super important. We couldn't do the half of what they do We'd be completely lost without them. So just a big shout out to all the teams out there. And then my two business partners on the top is Dr. Francisco Carlos on the left and Dr. Vishal Gohel. Sorry, on the top left is Frankie, and on the bottom left is Vishal Gohel. These are two genius level periodontists in my estimation, and even better friends and people. And so I'm just honored to work with them day in and day out. And then on the top right is my buddy Gordon Evans, who's the regional manager for ZimV in our region. And I saw him yesterday, and I meant to ask him how many years it's been, but that he's been with the company. But he was super green, coming out of he was some kind of an accountant when I met him, and that had to be 20 years ago. And he's just been super loyal, taught me a lot, connected our practice to so many things, and I'm super just happy to call him one of my best buddies. So thank you, Gordon. And then Curtis Adams is on the bottom right, is a territory rep for one of our offices. He's a rising star at ZimV, no question about it. And Curtis, we appreciate what you do for us week in and week out. So, okay, as an overview statement, this Verla, if I'm saying it correctly, in 1998 first showed us that immediate implants with provisionals in the maxillary anterior could actually work. And since then, there have been a slew of studies that substantiated the viability of these treatments, as we all know. And the key to the procedures, I think, is really just understanding the diagnostic indicators, but also the biology that's involved. And so our goal, as Dr. Khan said in his, was it 2018 Perio 2000 article, was simply, we're just trying to preserve the existing bone and tissue architecture. And so, yeah, it follows that as surgeons, we'd want to pick a surgical approach that works in our hands based on our experience and our understanding of the literature and science, and that again preserves the bone and tissue, and of course minimizes complications. And so this is not a lecture suggesting what you guys should do in immediate implants in the anterior. It's just what we are doing in a lot of cases. And even in our practice, each of the doctors have their own little tricks and techniques and favorite approaches. So again, tonight we're only talking about maxillary immediate single unit anterior cases, just to keep it simple. And we'll run through dual zone and show a video and talk a little on dual zone with connective tissue, grafting with the video, and then we'll tee up socket shield, as I said, for either myself to cover in the future or one of my partners. Because there's a lot to cover, and we have 45 minutes, a lot to cover on socket shield, super interesting topic. And then eventually it may be appropriate to cover IDR, which is immediate dental alveolar restoration, DeRosa's technique, but we won't cover that tonight. We'll just cover the definition real quick. So let's do cover some of these definitions. Dual zone is Tarnow and Chu's flapless procedure where the tooth is extracted. The implant is placed palatally and hopefully in a screw retain position to give our restorative colleagues, the opportunity to go screw retain or cement retain, whatever their preference is. And then particulate bone is packed between the buccal wall of bone and the implant. This is called the bone zone. And then the bone graft is continued coronally from the bone crest up to the free gingival margin, which is, of course, called the tissue zone. And so this grafting, together with the prosthetic seal out of occlusion, helps maintain the ridge width and the tissue width and contour. And then the socket shield, as everyone knows, is similar, but instead of extracting the entire tooth, we section the tooth and leave the buccal portion of the tooth as a shield. This is Herzler's technique from his 2010 article, which is proof of principle animal study. And we know that the beauty of the shield is to preserve not just the periosteal blood supply facially to the thin, buccal plate, as the dual zone does too, because it's also flapless, but also to preserve the palatal blood supply as the shield maintains the periodontal ligament blood supply as well. There's also, of course, bone graft placed in the jump gap if there is one, most times, depending on who you talk to. And again, a prosthetic seal out of occlusion is essential by way of either a full contour provisional out of occlusion or a customized healing abutment. So Dr. Gluckman and his group and Herzler and his group and others have done so much work to help us doctors understand this technique sensitive procedure and to streamline the important aspects of the steps involved, while helping us minimize the complications. And then just to say again, IDR is a flapless procedure, and it's DeRosa's answer for how to handle compromised sockets post-extraction. And in his case, some of these sockets are blown out. So after extraction, the implant is placed. You got to get primary stability, and the defects are then grafted, most commonly with tuberosity bone or tissue and/or tissue. And this is all based on DeRosa's elegant classification scheme. And as I mentioned, we won't talk about this technique tonight, but hopefully we can cover it in a future webinar. I'm signing up for one of his courses in 2026. Finally, the stars have aligned. So I'm excited to finally get some hands-on training with him. This is a decision tree I put together to illustrate how I think about these immediate implant strategies in the maxillary anterior. I think it's important to think about these approaches not as one is necessarily better than the other, but more so what strategy is best based on the diagnostic factors and or indications. In other words, how the case presents. And then, of course, how it flows as you go through it, because things can change. So you may be targeting socket shield, and then the shield fails or becomes mobile, et cetera, and you default to dual zone with a CT graft or without. And then certainly there are many times when I've wanted to do dual zone, and post-extraction bone anatomy just does not allow it. And so we'll default to a delayed strategy, socket graft, or early or some other delayed approach. And of course, to take the pressure off, the patient has been well informed at the consult that we have these immediate approaches, one or two or whatever we're going to present to them as the one that we're going to try, and all the details about them, but also the fact that the case may shift to delayed, and it's a chairside decision. So we want them to know this up front, because we don't want disappointment if the immediate isn't the right choice, to make. We just want to do what's going to work best. And we don't want to be pressured by some preconception that the patient has or has locked onto or something. So let's quickly run through the diagnostic factors that we look at in these cases. So it's, of course, a broad topic. This takes a career to kind of learn all these things and get them in your head, certainly our training. So we can't cover them all, so we're just going to fly through a few things here. We have patient factors. There's systemic health, looking at their medications and risk factors. For example, I don't place immediate implants in smokers by and large. I've just learned the hard way on that. I know that there's literature to say that it's okay to do that. There's literature on both sides of it, but it's my preference to steer away from that. We consider the patient's supportive periodontal therapy compliance in their home care, and obviously we do a full periodontal evaluation. We're periodontists. That's what we do. We think through age, especially on the younger side, with the concern of continued vertical facial growth. We have to look at the smile line and lip translation and what's the patient's aesthetic expectation? And are they willing and able to undergo any additional procedures that may be needed to get a healthy aesthetic outcome? There's tooth-related factors. We diagnose the reason the tooth has to go. We use CBCT, of course, as everyone does now, to look for surprises like periapical pathoses, things we wouldn't be able to see clinically or on 2D. We look at mesial-distal spacing, sagittal root position. I still love Kahn's 2011 article, where we have these sagittal root position classifications 1 through 4. And of course, regarding primary stability in class 1, we can grab apical and palatal. Class 2 and 3 are a little different. Class 2, we're going to grab mostly apical. Class 3, buccal and apical. And then with class 4, most likely we're going to need augmentation, and immediate implant placement is contraindicated. And then we have our hard tissue considerations, like how's the buccal wall looking? The socket shield is contraindicated when the buccal wall is deficient, at least for me. And if you go dual zone and you have a deficient buccal wall, you may decide to slide a stiff collagen membrane in the socket, like Biomend Extend or Copias Extend. And then the bone graft between the membrane and the implant, of course. But we know the deeper and wider that defect gets, the more risk for bone deficiency buccally over time, which then can be associated with recession, right? So I generally won't do dual zone if there's a defect greater than 3 millimeters in the fascia wall, or if it's U-shaped instead of V-shaped, especially in high aesthetic cases, because there's just less predictability for me. So another thing we look at is how do the adjacent teeth or implants look? Do they need some sort of treatment, and when would it be? How do their prognoses play into the overall treatment plan? We'd also look, of course, at anatomical structures like the nasopalatine canal. And is it going to affect our placement? And do we have the minimal bone availabilities that we see in this chart, which is from this article that we all know so well? There's soft tissue factors like gingival phenotype, knowing that a keratinized tissue height and depth of 2 millimeters or more is correlated with, of course, tissue and bone stability at our implant. And is there recession on the neighboring teeth or implants? And do we treat it before, during, or after the problem tooth that we're treating? And then is there altered passive eruption, for example, that we might need to call in ortho on, or do some sort of aesthetic crown lengthening, either at the time of placement or before or after. And then finally, there are occlusal and spatial factors. Is there bruxism to consider short-term in our provisional and even long-term in terms of its effect on our implant and the restoration? Is there proper restorative space and running room for the emergence profile? I prefer to use a full contour provisional over customized healing abutments because I think the proximal contacts are important for maintaining and holding that papilla. So I always take a super close look at the potential to have that full contour provisional during my consult. That still, after occlusal adjustment to get it out of centric and eccentric, looks like a tooth when we're done, right? So taking a close look at that. And we know we want our implant to be in a trajectory that targets the cingulum to give our restorative guys a chance to restore it the way they want to. And of course, the table, the implant's going to be 3 to 4 millimeters from the anticipated free gingival margin. And in our practice, we're going to use either the Navigator guided kit with static guide, or XNAV with all of our ZimV implant placements. So in summary, we're all very well aware of these things that we have to evaluate and think through diagnostically, so I'm sorry to bore you with them. They relate basically, if we summarize it to the patient and to us and to the site. And to me, it's important to low-key sort of assess the patient's risk tolerance and let patients know that implants can fail, and that if you have a warranty, you talk to them about it, because if you do not and you have a problem and you're talking about it after, then it's an excuse. And I always remember this Hoff article where he found that 150 patients, that only 12% of them were willing to take on increased risk to shorten treatment time. So in patients that come right out and say something like this to me, and I think that I can get the same aesthetic result with a delayed approach, I often will just plan a delayed approach, because I'm not, it's not because I'm thinking that a delayed approach has significantly lower risk of failure. In fact, my understanding of the science is that it doesn't necessarily, but more so I'm just listening to what the patient is asking for so they aren't upset should we want to run into a problem, because it's their interpretation that immediates are a bit more risky, because it feels intuitive. I'm just not convinced that it's true. And yeah, we need to think about our risk tolerance, as it says here, and our abilities with the different approaches that we use, especially as the complexity and difficulty increases. And with regard to site, I like Dr. Khan's summary statement in his article, again from 2018, that for this to work, we need primary stability, and we need favorable anatomy, and we need manageable aesthetic risk for this all to come together. So let's talk about dual zone and dual zone with CT graft. If we have a mobile, non-intact buccal portion of a root, we are not going to necessarily do a socket shield. At least I'm not going to do it. And so it's kind of the wild, wild west out there. So there are people who have different guidelines for their socket shield, and amen to them, because they've figured it out. And I'm still in the learning curve, so I'm not going to be as aggressive. So if I'm not going to do a socket shield, I'm either going to do dual zone or dual zone with the CT, and the CT is determined by the gingival phenotype. In other words, whether or not I will do a CT graft. This is the classic two-part study of Tarnow and Choose that pretty much put dual zone on the map for a lot of us. It was retrospective, but it included 49 patients, and it looked at the change in the horizontal ridge dimension after immediate implant placement, largely in the anterior. And there were 4 groups from left to right. There's no bone graft and a stock straight healing abutment. And then there's no bone graft and a customized healing abutment. And then a bone graft with a contoured stock healing abutment. And then D is more what we're aiming to do, right? Which is a bone graft and a customized provisional. And they measured the cast from 6 months to 4 years from the time the final restoration was placed. And as we know, the bone graft and the provisional showed the least ridge reduction, with an average of 0.3 to 0.4 millimeters loss in that coronal aspect. There's like 1 to 2 millimeters from the gingival margin, pre-gingival margin. And that is summarized here in the box in red at the bottom. So they were comparing these measurements to the untreated contralateral tooth as the control. So on average, less than half a millimeter change with this procedure. And then in part 2, they looked more closely at the tissue zone, utilizing sort of the same design as the other, that part 1 study. And they measured the tissue dimensions on the cast at the time of the final impression. And the data showed greater soft tissue height and thickness when a bone graft was used versus when it wasn't, and the soft tissue thickness was greater at the sites that received a bone graft and a provisional, compared to sites without a bone graft and a provisional. So clearly from these studies and others, bone grafting is key in this procedure, as is the customized provisional or customized healing abutment. And again, in summary, about less than half millimeter of change expected. So let's jump to our video case of a dual zone approach. This 62-year-old healthy male and his dentist and endodontist referred him with a suspected vertical root fracture and an associated periodontal defect there on the mesial and mesial palatal. There's class 1 mobility. His smile line, I would say, is moderate to high. And the buccal wall, as you can see on the CAT scan cross section there, appears to be intact, and his bite allows for a full contour provisional out of occlusion in my estimation. He has a relatively thick gingival phenotype, and I think it's helpful that the gingival margin at number 8 was coronal to that of number 9. And so with the mobility and the possible fracture, we opted for dual zone, and we did not feel that a CT graft was necessary due to the fairly thick tissue there. So in this case, we used a 4.3 by 13 millimeter T3 Pro. This implant has even better primary stability than the predecessor, the T3, with its tapered core and the increased thread depth. And of course, with the 4.3, we're getting the platform switch benefit. One of the cool things about ZimV is they'll listen to their clinicians out in the field and make changes on their implants. And one of them is this, I think, ergonomic collar design. For example, on the T3 Pro, and with that thinner collar on the last few turns of the implant, you're less likely to sort of get hung up when you're trying to get to depth. And then, of course, on this implant, there's the hybrid surface with that proven OsseoTite fine micron feature along the whole length, and then it's the coarse features that are superimposed on the body of the implant. And the OsseoTite surface in the coronal, of course, helps to resist periimplantitis and, of course, stabilizes the bone in that region really well, too. And that's resistance to periimplantitis is probably a lot to do with the bacterial adhesion on the OsseoTite that is similar to the commercially pure titanium, which was seen and demonstrated in this study here. We also use the new pink matte finish encode to scan for the provisional in the video. The scanning is a little bit easier because it's less reflective than the old silver encode healing abutment. And then I switched to a silver 4 millimeter older healing abutment to sneak under the provisional in the video, because the patient had to wear a provisional for 1 day before the LAPRA process provisional, fixed provisional, was fabricated. And then also you'll see the placement of cancellous puros in the bone and tissue zone in the video. And there's just super good data on this product in that the graft sort of mimics the natural human bone. It seems like I'm reaching for puros pretty much every day because of that. And then, of course, there's a very robust safety profile on the product. So let's see if the video works. And hopefully I'm still going. I don't see Gordon calling me. So we're just checking the occlusion here to make sure, again, that we think there's room for the provisional, the fixed provisional full contour.
You're definitely still going, and the video is playing super well.
Oh, God bless. And then 15 blade or 15C, just to release the fibers and starting to feel the periodontal ligament space. This is a Periotome that I love that's actually made by another company. It's not made anymore, but any Periotome that's strong and thin and can sneak down the periodontal ligament space. Usually we're doing the work mostly from the mesial and distal palatal to try to preserve the bone on the buccal side. And you can get pretty vigorous with this thing. Finger over the buccal plate, as we all know that we're usually doing kind of a rotational movement to remove the tooth, protecting the buccal plate. And then we're going to, of course, curette all the granulation tissue out of the wound. This one had a little bit more than as typical because of the periodontal defect. So sometimes we'll take a blade around the coronal part to release those tenacious fibers and just release them a little bit easier, makes the debridement a little bit easier. We definitely do that a lot in the posterior with those blown out sockets instead of digging at that stuff. And then we got the starter drill. We're going to kind of lean into the palatal wall. This is an X-Nav case. You can see the X-clip on the patient's left side. And we just drop down the palatal wall 2/3 of the way down. The light is kind of going on and off because I'm looking at the X-Nav screen. For those who haven't tried X-Nav, I would highly advise it. It's a super cool product. There's the 2mm twist drill to depth. The bone density was feeling really good. So we went to the 325 by 13 to depth. And then probably shortened with the 4mm drill to like a 10 or an 11.5 and lean into the palatal wall a little bit so we don't get pushed to the buccal with the implant. And take a peek with the directional indicator to make sure we are where we think we are in that cingulum directional area. And there's T3 Pro. The gingival margin, remember in this case, is coronal by a millimeter or so. So we're going to go below the tissue level like 4 or 5 millimeters. And this thing drill was probably set at 20 newtons or so. And it torques out. And then we'll use the some hand tightening with the ratchet, and it definitely torques out north of 35 newtons. I still love to use the bone profiler on these cases because we need the provisional to be able to seat and not be impeded from seating fully. So then here's our healing abutment. We're going to do the intraoral scan after we take a PA. We take the healing abutment out. We're going to place the cover screw to keep the bone graft out of there and start packing the Puros into the bone zone. And everyone has a different technique. I mean, this is double time too, but to save time. But I just use the pickups, the perio probe, just fill it as fast as I can. Some people like to place it in and then run their implant in to carry it down. Slurry technique, they call it. A lot of different ways to do it. So then we're going to suction the top of the cover screw, take off the cover screw, put the healing abutment on. And again, here we're using the old one, as I said earlier, because we have a provisional that requires it, a 1-day provisional. And then we'll pack the tissue zone with the Puros. And again, a little bigger defect than usual, so it took a little longer on this case. And then we're going to come with just some CollaPlug and lay it over top of the bone graft. And that will sort of clot up. And we just tell the patient, look at no rinsing. You can eat and drink, but no rinsing vigorously up there. We don't want to rinse out the good stuff overnight. So now the laboratory is making the provisional. Very often the patient will keep the removable provisional in to sort of protect the area. We'll come back and all we need is topical. We'll push the CollaPlug to the buccal, take off the healing abutment, check that there's no bone particles over the seating surface of the implant, place the provisional. And with the patient not being numb, it's good because you can get feedback from them about what they're feeling. And we'll torque to 10 newtons, check the contacts, listen to what they're saying about what they're feeling mesially and distally, just rubbing off a little bit of the CollaPlug. And then we start working on the occlusion. 9 times out of 10, these things are almost perfect. So there's not a lot of adjustment. Here we're just doing some protrusive adjustment, which is super important. And it's one of the reasons why it's hard to do full contour provisionals when you have both centrals being replaced, unless there's anterior open bite. So now we're just doing the simple restoration, Teflon tape and composite, double check the occlusion, and just notice, we have some excess tissue there at number 8 relative to 9 that we knew. And so along the way, we were asking the patient if he was cool with that, because we certainly could have trimmed it back, but we just decided to let the provisional do its work of guiding the tissue and the healing. And as I said, he was good with that. So the bottom left is the healing abutment, or the PA with the healing abutment for validating that it was seated for the before we did the intraoral scan. And then on the bottom right is post healing abutment and bone graft. And on the left side here, that's the day we sent the patient to the restorative dentist to begin the final restoration. And on the right is a month or two later with the final restoration in place. And there's a CBCT from that day to sort of check the buccal bone, which appears to be stable and fairly thick. And then again, here's the pre-op on the left side and the final photos again on the right. So you look at this and you then wonder if there was that anticipated 0.4, let's say, millimeters of ridge width loss at the coronal aspect of the treated site. And you can look at it here and it kind of looks like there is. Unfortunately, I did not get a pre-op occlusal photo. This is the final photo, but my guess is that we lost about a 0.5 millimeter on that number 8 and possibly more. But then if you look at 7 and 10, there's some asymmetry in the sort of buccal gingival contour there too. So it's hard to say. It's important to get the pre-op occlusal photo. But again, I think all in, this will be a very stable long-term solution for this patient. So what about CT grafting with dual zone? Cons published on 2 techniques that seem to be the most common approaches. This is the bilaminar CT graft approach, which is what I would most commonly do. And I'm definitely more thoughtful about performing this technique when the buccal bone is super thin. Because with this technique, like we said, we lost the periodontal ligament blood supply, so compromising the periosteal blood supply can be a concern. But there is literature to show that, yes, you may lose a little bit of that bone from doing this tunneling or VISTA approach, but the tissue more than makes up for it. So, and truthfully, I haven't had any clinical problems really to speak of by doing this CT graft with my dual zones. In the case we just saw at the video, had I done the bilaminar approach, maybe we wouldn't have seen that slight depression on the buccal of number 8, but hindsight is 2020. And so I have a short video of this bilaminar CT graft approach of cons. This is the case that I'll show here after. But this 46-year-old female, and she's healthy. She had a failed implant at number 11 and a mobile periodontally involved number 10. And so we did this one just a few weeks ago, but the prosthodontist, orthodontist, and I decided to remove the failed implant at 11, socket graft the site, and move the posterior segment medially orthodontically to substitute 12 into the 11 site there. And then placed an immediate implant dual zone with a CT graft at site 10. It was a low smile line case, but the patient agreed with me that it might be nice to try to bring the gingival margin of 10 closer to number 7. And I thought, looking at the tissue pre-op, it looked a little thin for an immediate implant. So the top is her initial photo, the bottom left is post-ortho, and the bottom right is 2 weeks from the immediate implant with dual zone and CT grafting. And we were super pleased with the coronal growth of the tissue and the thickening in the early healing phase. And this was a Navigator static guide case, and the image on the right with the green overlay showed that there was a good bit of bone on the buccal, so I wasn't really worried about compromising the buccal blood supply there. And the PA on the bottom is from the day following the surgery with the provisional in place. So let's just look at this super quick video if it will work. This is a bilaminar approach. So the implant's already placed. You're just going to tunnel either sulcularly or with some sort of vestibular approach, whatever your preference. This is the modified Orban, Pat Allen's design Orban. And we're just going to go split thickness beyond the mucogingival junction. We're sort of anticipating, based on Khan's suggestions, to have about a 9 mm long CT graft that is wide enough to sort of cover the tooth. And then this is double time again video, but using a single incision approach on the palate horizontally, and then coming in to separate the epithelium, and then back in to separate the connective tissue graft from near to the bone. And then we'll just go ahead and outline around it like we all do, I presume. And remove that graft. We very often will put some PRF in the wound and then a couple of resorbable continuous sutures. Hold some pressure there, and very often we'll also use a sort of a suck down Essex style retainer to cover and protect the wound, prevent bleeding, compress the PRF, etc. And patients do not complain about the palatal wound when you do PRF and you use a palatal stent. It's a game changer. Because now we're just trimming the epithelium off the tissue, going to leave the fat there. And then the suturing technique is the one that Khan describes, where if it's a 9 mm graft, you would go in about 6 mm from the margin, come up through the sulcus. So then you'd grab the graft about 3 mm from the base or 6 mm from the top and do a little horizontal technique, and then go back through the sulcus and back out at around 6 mm, a little more distally, and that will draw the graft in. And my head unfortunately got in the way there. Sorry about that. And then if she wants to peek up a little bit there at the margin, we just tuck it in a little bit with a Glickman and another horizontal mattress. So it's a very simple and quick approach, but the results are almost always good. So that is the CT approach that I use the most. Then there's, of course, the scarf graft option that Khan has also identified. It's what he calls a little piece of sashimi, which is kind of what it looks like. And it's an option if you want to thicken that tissue with one of your dual zone or socket shield approaches, what have you. But you don't want to compromise that buccal blood supply. And so Khan in this study looked at 22 cases and showed that the marginal tissue thickness increased. Well, it basically doubled, more than doubled. And he had 2 sites that partially necrosed, but they went on to continue to heal, much like our CT grafting around teeth, right? They sometimes will partially necrose, but by and large, they will almost always work. And that was his experience with these 2 necrosing scarf tissue grafts. So let's then switch gears real quick. And I know we're late because we lost a little bit of time, but 7:56. So we can fly through this. Let's compare the dual zone and the socket shield. So this is a article by Shadad, 2022, and he looked at 20 implants in the aesthetic zone. It showed that dual zone at 8 to 10 months, showed pretty much what Tarnow showed us, which is 3 mm ridge reduction, where the socket shield actually gained 0.1 to 0.2 mm of ridge. So that's like a ½ millimeter difference, right? But essentially you lose nothing with the socket shield. All the implants integrated. There were a couple of shield exposures, which is a common complication with socket shield. They were all managed. And like I said in the beginning, there's a lot of interest in socket shield in terms of research and on the lecture circuit. And I think part of it is this little 0.5 millimeter improvement, like the fact that you lose nothing. In dentistry, that's a big deal. And there is a steeper learning curve with socket shield, and Gluckman's article in 2018 showed a complication rate of 20% in 128 implants. And the majority were internal shield exposures, but all the complications were managed. And some of the other complications are external shield exposure and infection of the shield, shield migration, soft tissue invagination between the shield and the implant. And in 2024, Gluckman published an article with a technique to handle these internal exposures. It involves reducing the shield with a high speed and then suturing in a little bit of connective tissue, much like the scarf tissue graft from Dr. Khan. And you can see it in the pictures there. And then you replace, of course, the provisional over top, or depending on where you are in your treatment, it might be the provisional, it might be the final that you're replacing. Has also identified some of the keys to prevent complications. And the big ones that they seem to talk about the most are having the shield about 2/3 the length of the root, or 6 or 8 millimeters, let's say, and to have a shield thickness of about 1.5 to 2 millimeters. And of course, having the coronal part of the shield at the bone level as opposed to above, which was sort of the original thought process. You're also going to chamfer the shield at that coronal part. And this is to allow for the tissue to heal between the emergence profile of your provisional over to the shield. You don't want to minimize that distance. And then the last thing is just having a jump gap distance to be able to put some bone down into the gap between the implant and the shield. And so in the interest of time, I can actually skip this. This is just to show one of my failures from about 5 years ago. So I'm going to skip that because it's not that important. One thing that's cool is nobody likes complications. So I love that there's articles coming out that they're basically trying to systemize the protocol of socket shield. And this is the second of 2 articles entitled SPOT, which stands for Selective Preservation of the Tooth. And it's a guided surgical protocol to help standardize the procedure. It involves a number of different burrs, as you can see, and steps, but I've found that it's most helpful in removing the apex of the tooth and kind of staying in the center of the tooth so you don't air to the buccal and perforate, for example. And when you're done with a couple of the first steps, the majority of the shield preparation is done as well. So I would encourage people to look at this. I've been using this with the XNav. So this is just the final case of a 51-year-old healthy male with a palatal root resorption at number 10. And I was originally thinking just to do dual zone here, but I was concerned, about damage to the buccal plate with the extraction. Thought it might be easier to section it. So we switched to the SPOT socket shield approach with XNav. And the first step is cutting the crown off. And then you'll use high-speed burrs like a round burr and a donut-shaped burr to remove the tooth structure sort of down to the bone level circumferentially. And the Versa burrs are then used to obliterate the apex. So on the left is the XNav plan, and you can see you can very precisely guide right into the apex of the tooth and a little bit beyond, which just gives you great confidence. And then I strayed from the protocol a little bit here, but I widened that to make sure we obliterated the apex and prepared the shield a little bit further. And then the mesial distal cut is made, and the palatal part of the tooth was removed. And then the shield shaping burrs were used. There's several burr kits that you can buy to help you with this. We thin the shield out and reduce it coronally to the bone level, as I said. And then there's a chamfer burr that you can use to create that necessary room between the shield and the emergence profile of your provisional. And then we just changed the plan on the XNAV, which is part of dynamic guidance, right? You can't do that with static guides. You would need another guide, but we just changed the plan and we placed the 325 by 15 implant and got good primary stability palatally of the shield. We go ahead and scan for the provisional and then graph the jump gap. And this is again Puros, all the way up to the tissue zone. Collet plug in place, just like with the dual zone, and Essex, which is the typical 1-day provisional that we would use. So when we do these cases, we send the scan, and then I always ask, because the lab techs change even at the same lab, right? So you can be on a roll and then you'll get a product sent back to you that you don't like. So I'll always have them send to me via text the design, which is this top line. Bottom left is me sending a text back of the change that I want, and then the bottom right they send back, and we go ahead and have it fabricated. And this has prevented a lot of problems from happening. And this is the following day, and again we just apply topical and push the collet plug forward, remove the healing abutment, and then place our provisional and adjust the occlusion. So that's the pre-op on the top, and the following day with the provisional in place and out of centric and eccentric occlusion. And as with all these immediate non-occlusively loaded provisionals, the patient is instructed, of course, to go on a soft diet for 6 weeks, because we don't want to, affect with micro movement, particularly the secondary stability that is occurring from 2 to 5 weeks, let's say. And we usually take a look at them at 6 weeks, and after that, they can pretty much eat what they want, remembering that it is a plastic tooth up there. So finally, you might then ask, why bother with socket shield given the technique sensitivity, the steep learning curve, and the complications that pretty much everyone talks about in their initial days of learning this technique. I think Khan said he was upwards of 20% complication rate as well, just like Gluckman's article. Well, there's, like I said earlier, about a 0.5 millimeter ridge width difference, really no ridge width loss in socket shield. And that's one argument. The procedure's been around for 15 years, so if there's going to be major problems, it would have already sort of died on the vine. And then the other sort of final advantage to speak of, and this is a big one, is regarding adjacent implants in the aesthetic zone, which we saw in Chin's article in 2023, and he showed that the inter-implant bone and the papilla loss was only about 0.4 millimeters when one or both of the adjacent implants had a socket shield done on it. So this is truly a game changer, because in the past, it doesn't matter what technique we used, you were going to lose several orders of magnitude of bone and tissue between your two implants in that anterior zone, no matter what you did. And here it's 0.4 millimeters. It's more typically like 2 to 4 millimeters. So it'll be interesting to see how the popularity of the socket shield technique continues to ferret out. There's so much literature coming out, it's sort of hard to keep up with. But I hope that for those that didn't know about it, that teaser was helpful. And that's a late stopping point, so I apologize. I would just say I would encourage those that haven't to really master the dual zone technique, or and use whatever provisional strategy you like. I used to make them by hand for many years, and then I just decided I'm never doing that again. Um, and it's important to have that technique as sort of a fundamental base technique, and it's, as I said, relatively easy to master. And then I would take a deep dive on partial extraction therapy if you haven't, and look particularly at the socket shield technique, because it's definitely becoming more mainstream and there are some significant benefits. And those that have mastered it are super high on it. So anyway, thanks for you guys' attention. I appreciate it.
Thank you so much, Dr. Golden. We did have some great questions coming in. So what is the hardest part of socket shield technique in your opinion?
So I tried to touch on that a little bit, and somewhere in the middle of the presentation, but I think it's, if you're not guided, it's trying to stay down the center of the tooth, right? And knowing that it's super important to eliminate the apex of the tooth, because there will be infection